Today's topic is on the Endo-Perio relationship. You must be aware of the heading itself is telling the diseases which are occurring for the endodontic origin as well as periodontal origin together. So what is the interaction between them, how they are transferred from each other, that we are going to discuss today. So, as you know, the classification of the diseases, there are pulpal diseases and there are periodontal diseases. So, these pulpal diseases and periodontal, they both are in the so close intimacy with each other. So, any disease which is existed with the pulpal or with the periodontal, hello, yeah, hello, and with the periodontal, they will interrelate with each other. So, when you do the diagnosis of any disease, so the origin of the disease is very important. So that not to complicate any diagnosis or treatment planning, because treatment planning will be decided according to the origin of the disease. So as you know, the differential diagnosis of the diseases, to get them differentiated between the endodontic lesions and periodontal lesion. It is very important, and how to do that we are going to see today. So usually as you know, the endodontic lesions, whatever the endodontic origin lesions are there, usually the symptoms will be appearing at the apical termination, that is at the apical area, and while the periodontal diseases, they are at the margins of the termination. So this is the difference actually. The pulpal diseases, whenever they develop any symptoms, they are usually at the apical area, while the symptoms which are of periodontal origin, they will be usually at the margins of the periodontium. But the clinical diagnosis, when you go for the clinical diagnosis, there will be always the misinterpretation about etiology. It is difficult to differentiate between the pulpal origin and periodontal origin. So, how to differentiate them, that we are going to discuss today. So because the treatment plan is always decided with the proper diagnosis, and the importance of the diagnosis is because whether to involve pulpal diseases or no, whether to treat the pulp or only periodontal treatment is enough. As it will be, sometimes if it is only pulpal origin, you have to treat only pulp. If it is periodontal origin, excluding periodontal, you have to treat only periodontal. Only the question will arise when when they are interacted with each other. So what are the pathways, how they get connected with each other, like endodontic and periodontal tissues, how they get connected? So there are two pathways which are getting connected with each other. That is the anatomical pathway, and second one is a non-physiological. You understood? First is anatomical, second one is non-physiological. So what are the anatomical pathways? That means whatever the anatomies are there with the tooth anatomy. And from there, if the lesions are getting spread, then that is called an anatomical pathway. And non-physiological means it is not in the, they are atogenic. So it's developed or acquired later. So these are the two pathways. In the anatomical pathway, the disease can transfer from the apical foramen, lateral or accessory canals, or through the dentine tubules. While the non-physiological pathways, they will be atrogenic root canal perforation. Atrogenic means while doing the procedures, if any perforation is occurring, that is called as atrogenic root canal perforations. And another one is vertical root fracture. So when you talk about the apical foramen, we have discussed many times about the apical foramen because it is the most key area of the endotreatment, because you are getting, whenever there is a pulpal involvement, you are getting confined within the apical foramen. This, you will be within this apical foramen. This is the apical foramen which you can see in the diagram, because it is the main principle and direct route to the perineum. You can see this is the pulpal canal and this is the perineum which you have seen. So there is a at the apical foramina there is a direct connectivity between the pulp and perineum. So any infection in the pulp can reach to perineum. Any region from the perineum can pass to the pulpal area to the apical foramen. So the major pathway is a apical foramen. Then next one comes to the lateral or accessory canals. So what are the lateral or accessory canal? As you know, anatomy of the tooth, if you go with the natural anatomy of the root area or pulpal space area, there will be central canal. Along with that, there you can see this accessory canals, which the canals which are passing laterally. Instead of opening at the apical foramina, they are opening towards the lateral area of the root that is in the periodontia. So when you see here, you can understand this apical foramina, it is the apical area on these lateral canals. They act same like apical foramina, but in the lateral area, which will be occurring at the periodontia. This is the pulpal area, pulpal space, which is getting open at the periodontia. So how much is the incidence? They are seen mostly in the posterior teeth and at the apical area, most of the 17% of the apical area will have this area, this apical one third, it will have 17% of the lateral canals. Means when you treat that periodontically, you should take care of this area. The middle area will be 8.8%, while in the coronal area, there is incidence is very low, 1.6% only you will find the lateral or accessory canals. So what are these accessory canals? The most of the time is that those are the extra canals which are seen other than the main canal. So this accessory canal, most of them they are seen at this furcation area of the molars. You can see this is the furcation area of the molar, and you are finding it as a uh, extra canal, accessory canals, which will be the connecting part between the pulp and periodontia. So on this X-ray, you can just see this what this accessory canal contain. They are same contents, same as a pulp in the pulpal canal. So it will have the connective tissue as well as these vessels. So the circulatory things within this canal, whatever is in the system of the pulp, that get transported to the periodontia. So this is the one view of the canal. Then next one is the dental tubules. Dental tubules, they get you know what is the anatomy, you know about the dental tubules, you must have learned in the second year. So whenever you are doing the cutting of the teeth structure, so this exposed dental tubules, they get they get open up and they get connected with the cement, and so that also serve direct communication between the pulp and perineum. Whenever you are doing any treatment procedures, they directly exposed to they get connectivity or pathway between the pulpal and periodontal ligaments. So what are the causes and where the dental tubules get open? That those causes may be developmental defects, diseases, or periodontal procedures. So whenever you do any scrapping or flat anything on the periodontal, that time also you are opening the dental tubules and you may get connected with the cementum to periodontium. So these are the diagrams. So these are the anatomical pathway through which how it get connected with each other, this pulp to periodontium. So this what are these non-physiological pathways? That is the iatrogenic root canal perforations. As you know, what is the iatrogenic root canal perforation? Uh, Done with the operator without knowing having the knowledge of the exact canal. By mistake, they will be open up through the to the perineum. So this is the one of the complication during the dental procedure when you start with the root canal, and it will have the poor prognosis because it will be through and through perforation occurring between the within service internal anatomy to external periodontium. So this perforation can occur due to the rotary instruments when it can happen at the two phases. Initially at the where you start getting access to the pulp, then during preparation of the post is either while doing the root canal treatment, when you start locating the canal, when you start exploring the canal, when you don't find the canals, and if you start getting digging up here and there, that may lead to the perforation, or when you start to prepare the post, that time if you use the bigger side of the instruments, that can occur into the perforation. So that will be through and through channel formation between the pulp and periodontium. Pulp is spaced to periodontium. So any infection occurring either way will be get connected to each other. So next one is a non-physiological pathways. It is vertical root fracture. You must be aware about the vertical root fracture. Whenever there is a trauma or during procedure, it can, there is a possibility of the through and through fracture of the root, which is having again the poor prognosis while treating. So it can happen in both the ways, either in the vital or non-vital tooth. The incidence, because once you see for the incidence of the vertical root fracture, in which tooth it will occur is in this what happens whenever they are filled with the lateral condensation technique or tooth restored with the intracanal post, that can occur. What are the possible pathways for the spread of infection between pulp and periodontal tissues? So you should be uh, you just go through this diagram. If you go through this diagram carefully, you will understand. So this is the healthy pulp. How the healthy pulp convert to the necrotic infected pulp. Then how the healthy periodontium will convert to the infected periodontium. So if the patient comes with is when it is with the healthy pulp, so, so how that get interacted? Because both are in the close vicinity, pulpal as well as periodontium. If you see that how the bacteria get transferred from the pulp to periodontium, one there is a apical foramina, and if there is a vertical root fracture, the mode of transport can be from the apical foramina to the vertical root fracture. So if there is a apical foramina or vertical fracture, that will damage to the healthy pulp to the necrotic tissue. Then what is the other atypical foramina? It is accessory canals, lateral canals, dentinal tubules and vertical root fracture can be either both. It will lead either both the way. It will lead to the directly to the necrotic infected pulp. Then you see this, if there is this necrotic pulp tissue is there, that again that will via apical foramina, lateral canals and dentinal tubules and with the root perforation and vertical root fracture, that will infect again to the periodontium. So it is getting again interacting. But this, if there is a necrotic pulp is there, that will be through apical foramina, lateral canal, root perforation and vertical root fracture. It will convert this healthy periodontium to the infected periodontium. So this cycle will be on. So the main thing what you have to remember is how the bacteria get transferred is this same route. Again, apical foramina, lateral canals, accessory canal, dentinal tubules, root perforations, vertical root fractures, dentinal tubules, or root atogenic root perforation. Through that only the pulp is getting, infection is getting transferred from the pulp to periodontium. So once you know how it pathways, once you know the pathways, we should see for the etiological factors. What are the factors which are responsible for the pulp to get transferred? So the major cause of this pulp inflammation are, just note down if you want, instrumentation during periodontal, restorative or prosthetic dentistry. Whenever you do any instrumentation, when you start handling the periodontium or pulpal area, that get inflamed. So instrumentation during periodontal, restorative or prosthetic dentistry, or if there is a progression of dental caries, in direct and local trauma, whenever there is a tooth fracture. The next one is the dynamic of the pulp reaction is dictated by the virulence of the bacteria. Is how, because every case will not, the pulp will not get infected, but it depends on the entry of the bacteria and the virulence of the bacteria, how the host get responded, and how is the pulpal circulation is there, and the degree of the vascular and lymphatic drainage. How is the response, body response, accordingly the pulp inflammation will be decided. So, but what are the main etiological organisms which are responsible? Whenever there is infection, this mild pathogens, there will be bacteria, fungi and viruses. So once you know about the rationale, so we will be knowing what are the things it will be infecting the pulp tissue. So when you see for the microbiology, there is a change in the microbiology of the endodontic as well as the periodontal lesions. Because pulpal infections, they are mostly of the polymicrobial process, and most of them you will be finding with the strict anaerobics to facultative organisms, and so that the organism get increased once the infective processes proceeds. And while in the periodontics, you will find the actinomycomutants, which are already it will be there only in the aggressive periodontium. So most of them are the gram positive and gram negative non-motile. They will be divided accordingly. Whenever there is a pulpitis, we can see what are the organisms involved and what are the organisms which are involved in the periodontitis. So once there is a thing that whatever the pathogens they are present in the pulp, most of them will be always present even in the periodontal pocket. So they get involved even with the periodontal flora. They will be available in the periodontal flora. So, how to get clinical diagnosis? Once you know about the etiology, you know that both looks clinically similar, but how to differentiate them, whether that is a pulpal origin or periodontal origin. So, what are the clinical diagnostics tests are implemented? That that is important to know. So, what are the visual examination of the soft and hard tissue? How to come to the conclusive diagnosis? Before you go for the conclusive diagnosis, you have to check visual examination of the soft tissue and hard tissue. You have to palpate. Palpation should be done at the periodicular abnormalities or painful response of the digital pressure. Next will be the percussion. This percussion means you are knocking the tooth. In that, it will not disclose exactly the condition of the pulp, but it will show the inflammation of the periodontal ligaments. Then you have to check with the integrity of the attachments of the periodontium by the mobility testing, and that will show you the inflammation of the periodontal ligament and radiograph. So in this, when you start checking, doing the visual examination, so when, now in this visual examination of the soft and hard tissue, when you see the tooth, if the other tooth check whether it is a pulpal origin or periodontal origin. So on the visual examination, in the soft tissue examination, you will see that if the periodontal involvement is there, there will be inflammation at the lateral side of the tooth with slightly redness, and all the signs and symptoms of the inflammation will be seen. And in the hard tissue examination, If that is a pulpal origin, you will find the cavities and caries at the occlusal areas, means on the tooth side, hard tissues areas, and or in this, if that is a periodontal pulpo-perio relation is there, if there is any root fracture is there, which can be notified when you examine the hard tissue. And when you start doing the palpation, in the palpation you have to check with the, in the palpation you have to check with the, let's you have to check with the periodicular abnormalities if you are there, or any, if there is any painful response at the digital pressure. Whenever there is any pressure is, once you press the tooth or knock the tooth, you will get the pain. The checking the mobility is also one of the important criteria. Whenever the attachment apparatus like the periodontium is getting involved, that time mobility will be seen. On the percussion part, if your pain is tooth is painful on the vertical percussion, is when you knock the tooth from the vertical area or occlusal area, you will find the pain. That pain will be mostly of the pulpal origin. But if you do the percussion on the lateral side of the tooth, you will get the pain. That means it is a periodontial origin. The clinical diagnosis, even if you are going with the examination or vitality test, heat and cold test, most of the time the tooth will be non-vital. So you are doing the electrical pulp testing, cavity test, abnormal response. If any abnormal response is there, then that will show you the regeneration of the pulp. Then you have to check with the pocket also. If the pocket is there, so it will reflect you most of the time for the periodontal origin. And if any periodontal origin is there, that time also fistula can be tracked if there will be inflammation at the area, so that you can track the fistula. Even the cracked tooth syndrome, if there is any crack in the tooth, that will also again connect the pulpal as well as periodontal area. There is a necrosis of the pulp, or whenever there is abscess formation, or if chronic periodicular lesions are there, then there will be lesions when they are associated with the lateral or accessory canals. So you can very well assess them with assess them clinically. You can check them how are they clinically look alike. So once you know about this pulpal diagnosis, once you have come to the conclusion that the tooth has been involved to the pulpal down diagnosis, then how can you differentiate them to check that whether the periodontal diseases and the condition of the pulp, to check the condition of the pulp. So in this process of the checking, you will be having the so many factors which are responsible to see that whether there is a pulp is vital or no. Once you have checked with the pulp vitality, if the pulp is vital, most of the time that will be mostly originating from the periodontium, not from the pulp, because but if that get infected, pulp get infected in the due course of the things, the necrosis of the pulp can happen. So it is whenever there is a periodontitis, it will not make much changes in the pulp cavities or in the dental pulp. Dental pulp may not become non-vital because of the because of this pulpal periodontal origin, unless and until that get passed through the cementum. If there is an intact layer of cementum is there, then only it is possible. So how the the pulmonary perio lesions are get classified. Simon in 1975, 72, he has diagnosed endodontic and periodontal lesions. So classification is that first is only primary endodontic lesions with secondary periodontal involvement. Is the primary lesion will be from the endo origin, that is pulpal origin, and it is secondarily infecting to the periodontal. The second one will be the primary periodontal lesion, which is infecting the pulp. That is a secondary endodontic involvement. And third one is a two combined lesions. So you can see this diagram. You can check that how they are getting. You see, from the pulpal origin, it is going to the periodontium and it is getting passed. Second one, it is from the periodontium to the pulpal origin. It is the same, though it is a pulpal origin, still and perio origin will be here. The fistula formation is very common when there is originality of the endodontic problem, which will get involved to the periodontium. And what happened, the periodontal pocket get deepened due to this at the apex area, and then they get secondary involvement of the pulp and get formation of the individual lesions or independent lesions at the periapical or the marginal area. Okay, this is the second classification. In this is classified in the class 1, 2 and 3. The class 1 is a primary endodontic lesion, which can be accidental perforations, chronic periodontal lesions. Then class 2, which is a primary periodontal lesion, that is the advanced periodontal disease with or without extension in the apical area. Then secondary endodontic involvement. The next one is a class 3, they are combined lesions. So what is the cause and what is the condition of the pulp and what is the treatment? When the cause is of endodontic origin, then usually the condition of the pulp will be non-vital and you need to treat them endodontically. And when there is a cause is a periodontal origin, most of the tooth they will be vital and periodontal treatment is required. But when both the things are involved, endo and perio, tooth will be non-vital and you need to treat endodontic first, follow with the periodontial. Okay? So these are some photographs. How to treat them, we will see it in the next time.